Thank you very much, Professor Bertolini and Professor. It's for me, it's a great privilege and honor to be here. I am really impressed by the presentation that I have seen before from the director of the center. You are working, or you are here now in one of the top centers in the world, probably, in kidney transplantation, especially for living conditions. And I have seen in the Professor Fuda presentation that it is focused mainly on low immunological risk patients in general. So perhaps the next step for the talk would be to face with difficult high immunological risk patients. And perhaps this is why I am here today giving the first talk on this topic, because you have a challenge with immunological risk patients, because we are now suffering a lot with these kind of patients. The low immunological risk patients are not easy, of course, but we have been very happy with the results we have had during the last couple of decades, especially seeing this evolution in immunosuppression, etc. We now have to find a solution for those patients that have developed antibodies and have developed strong reactions against a lot of antigens, high PRAs, etc., etc. During the last years or decades, we have developed from the late 60s, where the CDC-NIH cross-match was developed by Terasaki in the United States. This was really very specific, so it measures the true death of the cells when you confront donor lymphocytes with the serum of the recipient, and you see a great specificity, but you lost a lot of antibodies with this reaction. You need a very strong reaction to become positive. With the passing of the years, we reached this flow cytometry CDC cross-match, and with this, we decreased a little bit the specificity, but increased sensitivity. So we were able to take more patients with reactions, but we were able to do transplantation with a positive flow CDC cross-match. We will see in a moment how this has decreased our good results, but if you do transplantation with a positive flow cross-match, but definitely you can do it, and you have more risk for antibody-mediated rejection, etc., but you can do it definitely. And then the last decade has faced the solid phase assays that are not taking the true reactions in the lab of cell death that CDC cross-match or flow cross-match are seen in the previous years. You see directly the antibodies that the patient has in the blood that will or not react with the antigen donors that you put with your kidney that are transplanted. Initially it was an ELISA technique, then the flow beads, and more recently the single antigen beads with the Luminex technology that I will show you in a moment. This is a receptor sheet, so sorry for the experts that I have to review a little bit what is the basis of these kind of diagnostic tools we have in the lab. Because all of us know what is a CDC cross-match, a classical complement-mediated cytotoxicity that we always do to our patients confronting the donor cells with the recipient sera, and we confront these T lymphocytes in the donor with the recipient sera and add rabid complement to increase the reactions. And if there are some antibodies in the blood that will react against the T cell lymphocytes of the donor, this cell will die, and we will see in the microscope, and the immunologists usually tell you, okay, this is a positive cross-match, which means the cells are dead because there is something in the blood, usually antibodies, that are killing these cells. Otherwise, if there is no antibody, you can put all the complement you want, the reaction is not appearing, and then the cell looks pristine, looks nice in the microscope. But one concept that I would like to transmit to you is that CDC cross-match is not finally a yes or no tool, is not a positive, negative tool, is not a dichotomic variable, it's a continuous variable. Has this any importance? In my view, it has, of course. Why? Because in the labs, in the immunological lab, finally, you count the cell death in the preparation, and if you are below 10%, you have a 1 point for the CDC cross-match. If you are between 11 and 20, you have 2 points, etc., etc. If almost all cells are dead, the CDC cross-match is by no means, of course, it is positive. So you will not do this transplantation. And if you have no cell death almost below 10%, you are sure that this tool, the CDC cross-match, is negative. But what about in the middle, the gray zone? By agreement, the labs, the immunological labs, have agreed that 1 and 2, so below 20%, the CDC cross-match is negative, and above 20%, it is positive. And usually, when a resident in immunology is in the lab looking at these cells and see, wow, 20%. So he's thrilled and called the senior immunologist to say, I have a CDC cross-match that is in the gray zone. So this is why this tool is not a yes or no. It's the evolution of decades after the Terasaki first observations at the end of the 60s, when we have agreed that what is positive and what is negative. And there are some gray zone parts that if you are a negative, have a negative CDC cross-match and then a very bad antibody-mediated rejection comes, perhaps it has been a gray zone CDC negative cross-match sometimes. And what is a PRA? The CDC classical PRA is an amount of micro CDC cross-matches in a plaque. You have the cells of the donors all over the area. Of course, in this hospital, you need a plaque with the donors that are usual in the area, not in California, not in Japan, not in Spain. You don't care these donors in terms of their reactions. And you do the 50, for instance, 50 simultaneous CDC cross-matches, and you see the positivities. And if a recipient has a 34 positives among 50, he has or she has 68% PRA. This is the only basis of this. Usual taking samples of different donors from the area, you have commercial plaques, and some plaques create their own plaques with the local donors they have. And this is a classical way to stratify patients. If you are above a given percentage, you can put it in 30%, 50%, 80%, 100%. Depending on the team, or the center, or the group, or the service, the department, etc., you will see this or that quoting as a high immunological risk or not. It has evolved a little bit. And you know perfectly, and I will not go through all these concepts, that the causes of HLA sensitization, which means a high PRA, classic PRA, or more modernly high MFI illuminate, you will see in a moment what does it mean, are transfusions, are pregnancies, are previous transplantations, and these are the three main factors for sensitization. But we have transplant nephrectomy as a rising potential factor. Some patients that are taking off a previous kidney, you see as the antibodies increase in the sera, so we don't know very well why it is. And some authors have argued that immunosuppression withdrawal in these patients could be in the basis of this increase after nephrectomy. So it is not only transplant nephrectomy, but also immunosuppression stop after the patient comes back to dialysis after a failed transplantation. And there is some debate on the possibility of maintaining some small amount of immunosuppression especially if the patient has another potential donor candidate. What is then a highly sensitized patient? This is a probably good definition. Potential recipient of the graft with an amount of circulating anti-HLA antibodies which limits notably his or her access to transplantation. And the question is that you have to define what is notably, because as you see, the definition is not giving you a threshold of PRA. In Spain, we have agreed a lot of years ago that the PRA CDC of 90 is a very high immunological risk patient, so that only 1 out of 10 donors will be compatible for you if you have a 90% PRA. In the United States, the UNOS have put this in 80% to quote a patient as a high immunological risk patient, recipient. Only 1 out of 5 donors will be compatible. So this is a 20% compatibility, 10%. And Eurotransplant is an European organization with 7 countries. Spain is not in Eurotransplant, has their own. We have our own programs, our own donor procurement system, etc., etc. But Eurotransplant, which is a joint of 7 countries, has this 85% definition. Has these high PRA any impact on kidney survival or patient survival? For instance, in graft survival, there is definitely impact. This is the CTS registry led by OPELS, including not only European kidneys, but also Australia, New Zealand, some Americans, etc. You see that above 50% PRA, you will have significantly lower graft survival at 10 years. 1 to 50% is also decreasing in survival in the middle between no PRA at all, so 0%, or over 50 PRA. So this is like a continuous variable impacting graft survival, which cannot be in other way because it reflects the antibody you have in the blood, and the higher the PRA you have, the higher the risk of graft loss. For instance, in Catalonia, we have the registry of renal patients, and in this 20-year evolution, to have an above 50% PRA is associated with a dramatic decrease to 53% at 5 years at graft survival, which is a very important impact. And this is only the classical CDC cross-match, which is done in the labs since, for instance, in 76, we did the first kidney transplant recipient here in Mansoura University. Probably at that time, this patient had a CDC cross-match at that moment. But during the years, it has evolved, and we now also do this flow cytometry cross-match, which is not only a usual T-cell CDC, which is usually the classical CDC cross-match. This includes B cells and T cells. And the main issue with the B and the T cells is that the T cells, the T lymphocytes, only have HLA class 1 antibodies. So HLA-A, HLA-B, HLA-C, etc. But the B lymphocytes have also have HLA class 1 and also HLA class 2 antibodies. So if you have a lot of antibodies class 2, so anti-DR, anti-DQ, anti-DP, etc., and only do a CDC classical cross-match, you are losing the reaction of these class 2 antibodies against the T lymphocytes, because the T lymphocytes don't have these class 2 antigens. So to take the reactions, the bad reactions, the positive reactions in a cross-match, and take not only class 1, but also class 2 during B lymphocytes. So you usually need a flow cytometry cross-match, which is usually done in living donation in many places. We don't do this in deceased donor kidneys because we don't have time to do all these complicated, logistically complicated issues for deceased donors. And this is why sometimes we have these bad injections, especially before the Luminex era that we now do, as you will see in a moment. So the antibodies adhere to the cell surface after also a stimulation of the reaction with anti-IgGs, anti-CD3s, etc. will do the positivity of the flow as a channel shift to the right. And this is a matter of technical issues that are not of great interest here now. But the question is that it mixes B and T cells, and it increases sensitivity. It is losing a little bit of specificity because you can have a positive flow without a graft loss during the first couple of hours, as you could have with the CDC positive program. You can have a positive flow without a disaster post-transplantation, but it clearly influences medium and long-term survival, as you will see it in a moment. And the last step we have done technologically is the development of luminance techniques with these plastic beads that are having attached these antigens to the surface, and you can have as many beads as you want with the different HLA antigens you have in the body. So you are simulating a reaction. You are not doing a true cell-to-cell reaction or cell-to-antibody reaction. You don't see dead cells, you don't see anything that is true biological. You only see the antibodies. So this increases sensitivity again. You take a lot of negatives in CDC and even negatives in flow. You take the antibodies with the proteins. You detect them, but you don't know if these antibodies are killing the cells or not when you put the kidney in your receipt. So this is a matter of technology. You detect the antibodies, you don't see the true reaction, the true biological reaction in the body. How does it work? We usually, because this is not a cheap technology, a complete analysis is costing around $200 American dollars, or around 200 euros per patient. So this is not prohibitive, this is not a great amount, but it is not cheap. So we first do screening in the patient, which is not 100 beads with all the antigens by the first step. Instead of this, we take some beads with class 1, some beads with class 2, and put the serum in contact with these plastic beads with the antigens in the surface and do a screening. And if it is positive, we have to go to the exact single antigen analysis with one bead with each antigen to see if the antibody is precisely against this antigen or another antigen. But if this is negative, you don't need to do single antigen. You only need the screening. This screening is class 1 negative and class 2 negative. You don't need to do single antigen. And you can say with a very, very high predictive value that your study is immunologically negative. And you don't have anti-HLA antibodies in the blood. You have some exceptions, but in 99% of cases, you are in a good shape having this screening negative. But then you look at the specificities. You compare with the donor HLA type you have, and you can have a CDC negative, you can have a flow cross-match negative, but you can have donor-specific antibodies in the blood of the recipient against 1, 2, or more antigens in the donor you are preparing for a living transplantation, especially those low amounts of donor-specific antibodies that can be with the flow negative. If you have a very high amount of antibodies, the CDC cross-match can be positive, and especially if this is class 1, as I mentioned to you before. If you have a very high amount of antibodies against the class 2 antigen, you will have a positive flow, usually. This is usually positive with a flow negative in those patients with a low amount of antibodies that many times are really pathogenic. Sometimes this 2000 MFI low amount of antibody with a flow which is negative for a cross-match, then you have a bad antibody-mediated approach. And this is because you have donor-specific antibodies, even though they are at low amounts in the PSA. This is the usual report that a single antigen gives to you. Each of these columns are different antigens, anti-HLA A1, A2, etc. Usually for a molecular typing that you need nowadays. And the conventional MF5 is a mean fluorescence index, which is the intensity of the antibodies you have in the blood. Above 2,500 is always considered to be positive in the pre-transplant analysis. If you have this high amount of antibodies, this is positive in all units. But then there are units that are considered to have a positive above even 500, which to me is very low. If you consider positive 500 study, you will have almost all your patients positive. So you need to put a cutoff, and there is no agreement nowadays, as it is with the CDC cross-match. Remember that below 20% is negative, above 20% is positive, which is a continuous variable. This is the same, but we are in the first birth of luminance. So this is a child, a small child. We need it growing to come with a good agreement. What is the MF5, the cutoff of MF5? We consider it positive or negative. It depends on the unit. And there is no universal agreement. For the post-transplant de novo PSA, so a patient that had a negative study, all greens before transplantation, but then a DSA appears after transplantation, we consider that above 1,000 is enough to consider a positive post-transplant donor-specific antibody. So finally, you have this report, and you have some antibodies that are positive, and a lot of antibodies that are negative, as you can see. And this again needs to convert a continuous variable to a nominal or dichotomic variable, yes or no, positive or negative, and it is a little bit difficult nowadays to convert this kind of variation. Has this impact in graft survival? A patient that is transplanted across a positive donor-specific antibody, so you detect with Luminex that this patient has an antibody above 2,500 MF5, but you do, instead of saying no, you do the transplantation. This is not that your patient will have a graft loss in a couple of days, as you will have it with the CDC positive cross-match, or in a year with a positive, strongly positive flow cross-match. You can have this patient with a functional graft without AMR. And this, what does it mean? This means that this antibody, this specific donor-specific antibody, is not killing the kidney. And we don't know why. Nowadays, we are not able to truly and sharply distinguish between those pathogenic antibodies and those resident antibodies that are going through the sera, not killing the organ. We don't know very well. We have done some steps. You will see in a moment that C1q positivity could be useful to distinguish this or that PSA. You have some IgG isotypes that are more pathogenic than others, but we don't know the exact way to distinguish them. What we know is that to transplant with a DSA on board is associated with a higher rate of antibody-mediated rejection, both acute and chronic forms, and it is associated with worse graft survival. We know definitely. What is the relevance then of these pre-transplant HLA antibodies? The first good paper showing the importance of having pre-transplant DSA is a Jason from 2010 from a French group, showing that in 400 patients receiving a kidney transplantation, a mix of living and deceased donor kidneys with a negative CDC cross-match, which is 100% of all the transplants that are done all over the world now, 83 of them, 20%, despite this negative CDC, had retrospectively had a positive DSA. So they were transplanted, and the team didn't know that they had a DSA because they were transplanted only with a CDC negative cross-match, as we have done for years and years. Look at the impact of having a DSA. This is the patients that had a DSA, the 83. The graft survival is significantly lower than those that have no anti-HLA antibodies, or those in a thicker line having anti-HLA antibodies but not specific against the donor, the non-specific anti-HLA. So definitely having DSAs before transplant are really associated with worse graft function, graft loss, increased graft loss in the middle term, 7 years of evolution. And what about a more selected population, which is almost 500 patients with a negative CDC and a negative flow cross-match? What have we done doing this flow cytometry cross-match? Discarding some positive flows that were negative in CDC. So some patients are at higher risk of rejection. So CDC negative, flow negative, but still 45 of them, so 10%, had donor-specific antibodies. The impact of having these antibodies instead of not having these states is also significant in terms of graft survival. Not that significant, including those patients only with CDC negative cross-match, but potentially positive cross-match, but also significant, as you can see. So a negative flow is not enough to make sure that your patient is or not sensitized against your donor. So finally, if you want to have the best possible survival in your patient in terms of immunological risk, you need to do Luminex assays. You need to do solid phase assays on top of the cross matches to discard or to make sure that you have the whole information. This is not to say that you cannot do transplantation with a DSA. You can do it because you see here that it is almost 90% graft survival at 4 years. So 90% of the patients have a graft functioning despite the positivity in DSA. So you definitely can do it. But if you want the best survival, you need to do something. Perhaps heavier immunosuppression, perhaps desensitization pre-transplant, perhaps looking for another donor who probably will not share these antigens, etc., if you want the top survival, as all of us are looking for. What about our own experience in Hospital del Mar? In 300 patients with pre-transplant analysis of DSA, which was retrospective again, 15% of them were transplanted with a CDC T-cell negative cross-match, as usually we did in the past. 14.9% had pre-transplant donor-specific antibodies. As you can see, most of them were DSA class 2. And they could be 20,000 MF5. And you don't take it with a CDC T negative because the T cells, remember again, don't have class 2 antigens. So you can have 0 anti-A, anti-B, anti-C, etc., but can have 20,000 anti-DR1 or anti-DR2, and don't take this reaction with the CDC cross-match. You take it with a flow cross-match if you have a high MF5, because of B cells do have these class 2 antigens, but not the CDC-T. So 29 patients were DSA class 2, 5 of them also with DSA class 1, and 7, curiously, had DSA class 1 that were not taken by these. Perhaps we haven't seen exactly these 7 cases in detail to see if these were this gray zone CDC positivity. We don't know the cell death in each of these groups, because this is not stored in the history of the patient to be treated. So finally, as you can see, short-term, to have a DSA pre-transplant with CDC negative cross-match didn't have a lot of impact. So acute antibody-mediated rejection was not that important in these patients, at least in our experience. But finally, the long-term outcome was not that good. You can see here significantly lower graft survival in those patients having specific antibodies against any antigens, HLA antigens. So this is a good conclusion. Transplanting across the DSA is associated with worse outcomes. And this is true in many, many papers that are now out there. How can we distinguish between those patients with a DSA that will do perfectly in comparison with those that are losing the kidney even at 2 or 3 years? We have tried to do it with C1q. If you have a DSA and your immunologist has the C1q kit, which is a little bit expensive, I can tell you, you can do this in the lab. And if this antibody fixes C1q, this complement fixing DSA, some authors argue that these C1q fixing antibodies are bad and the C1q non-fixing antibodies are not that bad. This is not functioning a lot in pre-transplant patients. This is working much more, as you will see in a moment, in post-transplant patients. If you have a new de novo DSA appearing, C1q positive DSA is really strongly affecting graft survival. But the distinguishing between C1q negative or positive, as you can see in our own experience, there is a couple of more papers out there, is not with any impact in the prognosis. So we don't do C1q testing in our pre-transplant DSA. What is the relevance of post-transplant HLA antibodies? We have seen the pre-transplant, and what is the post-transplant? This is not to stratify the patient, because you don't know the DSAs that your patient will do or will make during the post-transplant evolution. It is around 10% during the first year and 10% more during the coming years, at least in this series from Cincinnati in the United States. In our experience, this is a little bit lower with the kind of patients that we are usually transplanting. And this is the impact of de novo DSA in graft survival. These have 700 patients. This is a Lachman series from Charité Berlin showing 700 patients without de novo DSA with a great 75% 8-year survival. And you have the worst survival in those developing DSA, 40% at 8 years. So almost half of the survival if you develop a DSA. And in the middle, you have those patients that develop a new antibody against any antigen that is not specific from the donor. So non-specific DSA are also impacting somewhat, not that importantly as the specific antibodies, but impacting significantly in graft outcome. And this is our own experience. As you can see, the grafts are quite similar. No antibody is the best, 90% at 6 years. Having a DSA is impacting clearly. Sensory infiltrative function, 73 or more or less at 5 years graft survival. So much lower graft survival if you develop a specific DSA. And if you do the C1q analysis in post-transplant DSA, you can distinguish those DSAs that are bad, really bad, impacting the kidney and killing the kidney due to chronic antibody-mediated rejection, in comparison with those antibodies that are not that important. At least in the experience from the Necker program, showing in blue those DSA that were C1q negative in comparison with those that were C1q positive. You see a real important impact here between both subcohorts. In our own experience, in 47 patients developing DSAs in 5 years, as a median follow-up, having an anti-DQ above 7,000 is the worst possibility you can have for chronic antibody-mediated rejection of graft loss. This is quite frequent to have anti-DQ. You see that 28 of the patients developed anti-DQ among these 47. So more than half of our patients with a DSA post-transplant are anti-DQ, which is an antigen very, very prone to stimulate development of antibodies. But those with low amounts are doing well, no graft losses, and those about 7,000 carry about 50% graft loss in 5 years. So having 10,000 anti-DQ is a very bad situation. And probably this distinguishes even better than C1Q, probably, and it is much cheaper. So you have to adapt a little bit the knowledge to the possibilities you have. The C1Q kit is exceedingly more expensive than a simple single antigen movement. Another aspect that will merit a lot of discussion in the future will be the IgG isotypes. You have the DSA, and in the lab, the immunologist can know with some kits, immunological kits, what kind of isotype is this antibody. It can be IgG 1, 2, 3, or 4. As you can see, this French experience again, having a DSA which is anti-IgG3 is a very bad situation. So if you have anti-DQ above 10,000, if you have this antibody C1Q positive, and you have an antibody which is IgG3, wow, you're a bomb. You will lodge your kit. But if you don't have an anti-DQ of such amount, it's 2,000, 3,000 or 4,000, it's C1Q negative, and IgG1 probably don't do anything because your DSA is not that bad. This is a speculation a little bit because we need to confirm in much more serious, but we are now delineating a little bit what is the DSA true impact with this or with that diagnostic tools. There is a consensus guidelines published in transplantation that you can follow or not, because this is no more than panel expert opinions, because we don't have very strong data to say, okay, Louis Mansura should do DSA every year. We don't have such strong data to recommend, as we recommend if you jump from an aircraft, please put a parachute. So the evidence that if you don't do that, you have a bad prognosis is really strong. And this is the opposite. We don't know very well what to do with the information we get. So in the very high-risk patients, or in the high-risk patients, definitely we need to follow this DSA, because if this DSA is turning bad in terms of increasing MFI, etc., it is a bad situation that probably needs some treatment. The problem is that we don't know very well what treatment we need, and the treatment, of course, is beyond this talk now. In the program, there are some antibody-mediated issues that will probably cover all this. In the low-risk patients, which probably is the more challenging patient, what to do with the low-risk patients? Do we need DSAs in these patients every year? We don't know very well. We monitor for DSA at 6 months after transplantation in every low-risk patient, and then we do it yearly in every patient. Why? We don't know very well why. We are doing as a research project much more than a clinical standard recommendation. So finally, the consensus say that every 12 months, please store 1 serum per year in the fridge, which is cost-free, almost. And if you do relevant changes in immunosuppression, have a non-compliant patient, you see dysfunction in the kidney, and you transfer to other center, etc., etc. These changing situations, you can check always this sera stored in the fridge, and you can do a better idea of how is your patient immunologically behaving. We have an algorithm here, that is the algorithm from Hospital Anwar, what to do with the highly sensitized patients. The first step is to have a detailed immunological chart to record all the sensitizing events, transfusions, pregnancies, previous transplantations, etc., etc. We do HLA antibody testing with the three techniques we have, which is CDC cross-match, of course, and flow cytometry cross-match with a specific donor. But then we also do the screening for Luminex antibodies, and then if it is positive, the complete single antigen, to have the possibility to do virtual cross-match, which is not a true cell cross-match, as in the other possibilities, but a nice virtual cross-match to make sure that this patient is not with antibodies. And you can only say that this patient is low risky if all this is negative. But if you have a DSA above this or that MFI, is a matter of controversy, but if you have a negative flow with a negative CDC, but a positive DSA, you cannot say that this patient is low risk. You say that this patient is high risk. Among these high-risk patients, you can have a top high, a medium high. It's a matter of how you want to define it. And usually we explore the first step as you do. Identical siblings, and there are other living donors. The incompatible donors, we do evaluation of this mismatch. We do sometimes desensitization. I have to recognize that less and less we do desensitization, because finally chronic antibody-mediated rejection is coming in many patients, even though the acute antibody-mediated rejection is avoided with these techniques. But then the future prognosis of the patient is not that good. If you have a non-desensitizable patient, we go to our national fairly change program. It is not working in Egypt now, but perhaps in the future it could be. And the other possibility, of course, is to find a compatible donor. And in Spain, we do a lot of these donors that are usually the last solution for an incompatible living pair. We have strategies, and I will pass very quickly for this. The long-term results with in immunological high-risk patients, you have seen that are always worse than patients without immunological risk. But the Americans has stated that the desensitization treatment is better than waiting indefinitely for a disease donor that will never come if you have a very high P rate. So it is not wonderful, but it is better than nothing. What about ABO incompatible? Tomorrow, I think, I can remember that we'll have a specific talk on that, so I will pass quickly through this. And the final solution is a third donation. Could be a possibility here in the coming decade. My final slide is what were the classical criteria of stratifying the immunological risk. This is the typical, to me, this is a typical slide that could be 15 or 10 years ago, really nice. No induction therapy with the identical twins or even siblings. This is what we are even doing now, and was doing in our unit for a number of years. If you have a patient with a first transplantation with a CDC below 30% or retransplant with a CDC below 30 without previous immunological losses, in the past, with this, only with this, we said, okay, this is a low immunological risk, I will do similar induction. And then if the patient has above 30%, or is a retransplant above 30%, or with previous immunological loss, this was a high-risk patient, and I could find globally this induction. And this was associated with the given results that are good, but not exceptional. What is the current criteria in our unit? The same for the siblings, which is a very low risk population. So we do conventional immunosuppression without reduction. First kidney transplantation, receiving a first kidney without DSA, even with a retransplant, we do basiveximab. And for us, these are the low immunological risk patients. A kidney transplant with a PRA above 50%, with a virtual cross-match which is negative, so I do the Luminex screening and then single antigen if positive, and all the antibodies that I have are not specific, or even they don't exist. So this is a virtual negative cross-match. But despite these, above 50% we do fine. So we are conservative in this area, because there are units in the world, for instance in the United States, that doesn't do any more PRA CDC. If they have a negative Luminex, they say, okay, no antibodies. I don't care that this patient is 70% PRA, because all these antibodies are not specific, so I will not do thymo. But in many units they do thymo, regardless the PRA or regardless the Luminex, even in these patients. So in the United States, they use thymo for every patient and don't care a lot these complications, infections, etc., or cancer in the long term they can have. And finally, with the current or virtual or historical positive cross-match, so which is a Luminex with a DSA, we use ATG and previous desensitization in most patients. But I have to recognize that during the last couple of years, we haven't done this desensitization. We have looked for another donor or put the patient in the waiting list for a deceased donor, because we think that the chronic antibody-mediated reaction that we have with these kind of patients is too high to maintain our policy of doing desensitization. Do avoid acute, but don't